بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. آه، السلام عليكم ورحمة الله. Welcome everybody. It's my pleasure today to be with you again with our thyroid course in the third day. Hopefully we are in the last day. I hope that all of you got benefit in the first and second day of our course, and today we'll try to complete the journey inshallah with some topics which were not covered during the previous days. I have to also repeat my thanks for you as audience. I have to thank the organizers for the support, and I hope that inshallah today we'll enjoy the last day. I will start inshallah the first part of the today's topic, and the second part will be covered by my colleague Dr. Hamid inshallah after the in the second session. The first session today will be about thyroid diseases during pregnancy. This is the first topic, and with no further delay, I will start immediately to present this topic. We know that the thyroid diseases are common in pregnancy. Generally, thyroid diseases are more common in female. So we have more concern about thyroid diseases during pregnancy, provided that females are more prone to have thyroid diseases. We know that we have different types of or disorders of thyroid diseases, including hypothyroidism, for example, hyperthyroidism, thyroid nodules, thyroid carcinoma. Maybe I'll try my best to focus on the main issues or main diseases. I will try my best to make it simple. And as a reminder for all of you, if you are interested to follow in the diabetes and endocrinology field, please follow our Twitter account, EndoDMOS in front of you. It's a pure scientific account about diabetes and endocrinology, ENDODMOS. So if you like to have more update about diabetes and endocrinology from time to time, please follow us. Our agenda in this topic, including, as I told you, hypothyroidism, hyperthyroidism, thyroid nodule, goiter in general, thyroid carcinoma, and postpartum dysfunction. These are the outlines in this topic, thyroid disease during pregnancy. The hypothyroidism during pregnancy, I think it is the commonest among all disorders, and clinical manifestation usually are manifested like the other manifestations in non-pregnant ladies. Hypothyroidism, as we mentioned yesterday and day before yesterday, may be presented with fatigability. Patient may have weight gain, may have cold intolerance, hair loss, etc. And in the laboratory-wise, we know that if no trimester-specific reference for TSH, maybe you can use the upper reference limit of 4 as your reference and use trimester-specific reference for free T4. If it is not available, maybe you measure total T4, because total T4 in pregnancy usually is 1.4 higher than in non-pregnant women. What about the screening? Usually, interest in screening for thyroid dysfunction in pregnant ladies, the universal screening of asymptomatic pregnant ladies during the first trimester is controversial. There is wide variation in screening practice. Some may investigate symptomatic goiter family history or anti-TBO positive patient. What does it mean? If the patient has anti-TBO positive before pregnancy, it is recommended, or you can measure, or it is, we can say, preferable to go for thyroid function test measurement during pregnancy. Also, if the patient has a family history or goiter or symptoms, it is preferable to go for thyroid function test, and this is the usual what we are doing in the clinical practice. How to diagnose hypothyroidism during pregnancy? You can go with this approach. If the TSH, thyroid stimulating hormone, above population and trimester specific upper limit of normal or above 4, then you can measure free T4. So you go with this approach, TSH. If it is more than 4, measure FT4. If TSH more than 2.5, measure anti-TBO antibodies as well. So you can diagnose overt hypothyroidism with high TSH, low free T4, below reference range of pregnant. Usually the pregnant ladies have their own reference range. It is available usually in the kit of the laboratory material to know what is the reference range of free T4. And you can diagnose subclinical hypothyroidism with elevated TSH and normal free T4. Is antibody status is important in diagnosing hypothyroidism? Yes, because women with subclinical hypothyroidism and positive anti-TBO have high risk of adverse pregnancy outcome. And the adverse outcome, even in euthyroid women with high serum anti-TBO, include increased risk of fetal loss. So this is, you have to keep it in your mind. Anti-TBO positive hypothyroid, increased fetal loss, preterm delivery, perinatal mortality, large for gestational age. All are the side effect or adverse effect events associated with anti-TBO or hypothyroidism in general. So one more, or there are more, we can say, adverse events or adverse side effects related to hypothyroidism. I will ask you to answer this question. Pregnancy complication in hypothyroidism include all of the following except A, preeclampsia and gestational hypertension. B, large for gestational age. C, placental abruption. D, increased rate of cesarean section. Please give me your answer. I'll give you a few seconds. I want the exception. Majority going with B, some of you going with A, some of you going with D. Okay, good participation. Thanks for your participation. But actually, the correct answer is B. B is the exception related in this question. So let's talk about pregnancy complications. Risk is lower in subclinical than overt hypothyroidism. What are the adverse complications or adverse correlation with hypothyroidism? Maybe you can observe preeclampsia and gestational hypertension, non-reassuring fetal heart rate tracing, increased rate of cesarean section, perinatal morbidity and mortality, placental abruption, low birth weight, postpartum hemorrhage, preterm delivery, including very preterm delivery before 32 weeks, neuropsychological and cognitive impairment in children. IQ score is low in these children. So if we talk about mother, all the adverse event in front of you, but if you talk about the baby, the most important issue is cognitive impairment in the children with low IQ score. I have another question here. In hypothyroid pregnant women, it is recommended to keep level of TSH below which of the following? A, 1.5, B, 2.5, C, 3.5, D, 5. I'm waiting your answers in the chat box. I will give you a few seconds. So let's review together your answers. Uh, between B and C, some of you going with A. The correct answer is B, 2.5. So, good fetal and maternal outcome depend upon treating maternal hypothyroidism. Look for indication of treatment of hypothyroidism or subclinical hypothyroidism. The goal of free T4 or T4 replacement in pregnancy is to restore euthyroidism as possible, and your goal of TSH less than 2.5. What are indications for treatment? If TSH more than 4, free T4 below the reference range, TBO antibodies positive or negative. This is the first condition. This free T4 within the reference range, TBO antibodies positive or negative. Yes, again, second issue you have to treat. But if the TSH between 2.6 up to 4, measurement of antibodies is indicated, and if it is positive, treat your patient. Again, if the patient is patient has high TSH above 4, look for free T4. If it is low or normal, it means patient with hypothyroidism overt or subclinical with antibodies positive or negative, or an indication to go for treatment. TSH between 2.6 and 4 with positive antibodies, also this is an indication to treat hypothyroidism. General dosing guidance is as follows: TSH more above 4, low free T4 using trimester specific range. Full replacement dose usually are indicated or is indicated. What does it mean? Full replacement dose mean 1.6 microgram per kg per day. And the second issue, TSH more than 4 with normal free T4. It means you are talking about subclinical hypothyroidism. Intermediate dose, 1 microgram per kg per day is indicated or is recommended to start the dose. If the TSH between 2.6 up to 4, low dose as 50 mcg daily is recommended again. Usually in clinical practice, we are depending on TSH. So if TSH little bit above the normal, it means if it is 6 or 8 or 10, maybe we can go for 25 to 50. But if it is, for example, 20 to 30 or above, you can go for 50. But if it is, for example, sky high, like 100 or above, maybe we can go with a full replacement dose approach with 100 according to the weight of the patient. So maybe this is a rough way to how to approach your patient or starting the dose. But in the clinical practice, again, DSH value has a major role. T4 should be taken as on an empty stomach, ideally an hour before breakfast, but few patients are able to wait a full hour. So this is as in non-pregnant ladies, usually levothyroxine is recommended 1 hour before the first meal of the day. This is again a quick overview about management of pregnant ladies with or at risk of hypothyroidism. As you can see here, it depends on the TSH level. If it is less than 2.5, euthyroid treatment, levothyroxine not required. 2.6 up to 4, look for antibodies positive. Usually it is preferable to go with 50 mcg daily, especially if the patient has a history of recurrent miscarriage. But if it is negative, monitoring is advisable. TSH more than 4, free T4 is low. You can go for replacement definitely in these two cases, but the dose may be different in these two cases. I have a question here or a scenario. I want your input again, please. A 25-year-old female lady, female known to have hypothyroidism for the last 3 years. Her dose is 100 mcg microgram daily. She just did pregnancy test and it was positive. Her last TSH before 2 months was 2. She came to you asking your advice because she discovered now she is pregnant with a positive pregnancy test. What is proper action in this scenario? A, do TSH after 2 months and no need to adjust levothyroxine dose. B, increase levothyroxine dose by 80% and ask immediately for TSH. C, increase levothyroxine level by 30% and ask for TSH dose, TSH level, decrease levothyroxine dose by 30% and ask for TSH level. Please put your answer in the chat box. Let's review your answers. We have A, we have C. Most of you going between A and C. And actually the correct answer is C. If the patient has pre-existing hypothyroidism, goal preconception TSH also is the same as it is during pregnancy, less than 2.5. So early dose adjustment is advisable. Newly discovered pregnant should be instructed to increase levothyroxine dose by 30% and notify a clinician to measure TSH. Increase dose from once daily to 9 doses per week, double the dose 2 days each week during weekend is an easy approach. What does it mean? You ask your patient to double the dose, which is 100 in this example, to 200 during weekend, during Friday and Saturday. So measure TSH This is a precaution increase. And if TSH is high, you will continue this increased dose. But if it is normal, maybe you can go with the previous dose and monitor your patient. But as a quick response, you have to increase the dose by 30%. And this is usually more easy in the clinical practice to go with doubling the dose 2 days per week. Further dose changes are made based upon TSH measurement every 4 weeks until normalized. Then how to monitor TSH if it is not in the target? Usually every month you can measure TSH, but if it is in the target, maybe you can measure TSH every 2 to 3 months or every trimester. After initiation of levothyroxine, measurement of TSH in 4 weeks is advisable. The goal, as we mentioned, to keep TSH less than 2.5. If TSH remain above the goal, increase the dose by 12 to 25 mcg per day. Measure TSH every 4 weeks during first half of pregnancy because those adjustments are often required. TSH can be monitored less often, at least once each trimester in the latter half of pregnancy, as long as the dose is not changed. So if the dose is changed, advise your patient to measure TSH every month. If the dose and TSH is good, maybe you can go for measurement or monitoring every 2 to 3 months. I have video here. Maybe we'll try to summarize what we talked about.
Hello and welcome to Med Simplified. In this video, we will talk about hypothyroidism, that is low thyroid levels, and its effects on pregnancy. Then we will also discuss how you should manage your hypothyroidism during pregnancy. Pregnancy is a period that places great physiological stress on both the mother and the fetus. When pregnancy is complicated by endocrine disorders such as hypothyroidism, the chances of adverse outcomes increases for both the baby and the mother. Pregnancy causes major changes in the levels of hormones made by the thyroid gland. For that reason, thyroid problems sometimes can start or get worse during pregnancy or even after childbirth. The thyroid makes the hormones T3 and T4, which control our metabolism, which in simple terms is how your body uses and stores energy. When the thyroid gland doesn't make enough thyroid hormone, it is known as underactive thyroid or hypothyroidism. The symptoms of hypothyroidism can be confused with the hormonal changes of a normal pregnancy, such as tiredness and weight gain. So, low thyroid levels can be easily overlooked in a pregnancy. If left untreated, hypothyroidism in the mother poses a risk for both the mother and the baby. A pregnant woman's thyroid hormones are vital not only for her but also for the development of her baby. Pregnant women with uncontrolled hypothyroidism can get high blood pressure, anemia, muscle pains, and weakness. There is also an increased risk of miscarriage, premature birth, or even stillbirth. In our previous videos about hypothyroidism, we have discussed in detail why hypothyroidism occurs, what are its signs and symptoms, and how is it treated. We have also made videos about what foods you should include and which foods you should avoid if you have hypothyroidism. So make sure to check them out by clicking the I button above. Let's first take a look at what are some common signs and symptoms you can develop if you have hypothyroidism, and then we will take a look at why thyroid hormones are so important for both the mother and the baby during a pregnancy. When the thyroid gland produces less thyroid hormones than it should, metabolism slows down and causes a variety of symptoms. At first, the symptoms of hypothyroidism may not be noticed, but over time, these symptoms become more obvious and severe. These can include fatigue, weight gain, constipation, irregular periods, loss of sex drive, hair loss, brittle hair and nails, dry, itchy skin, difficulty in learning and memory, infertility, etc. The most common cause of hypothyroidism is an autoimmune disorder called Hashimoto's thyroiditis. The body's own immune system mistakenly sends out antibodies to destroy the cells in the thyroid gland. This may cause the thyroid gland to enlarge, and this is known as goiter. Hypothyroidism and goiter can also result from not getting enough iodine in your diet. Hypothyroidism can also occur after thyroid surgery or radioactive iodine therapy given to treat hyperthyroidism. In many cases, specific cause of hypothyroidism is not known. Thyroid hormones are vital for the development of brain and spinal cord of the growing fetus. In 1888, the Clinical Society of London studied the importance of normal thyroid function on the development of brain. Since that time, numerous studies with rats, sheep, and humans have proven that thyroid hormones have vital importance for various stages of brain development, including growth of the neurons, which are the main cells of our brain, and also for the development of the myelin sheath, which is like the covering of the neurons, and it is essential for their function. Studies have also demonstrated 60% risk of fetal loss if the hypothyroidism in the mother is not controlled. The fetus usually starts producing thyroid hormones when it is about 12 weeks old, but it still needs thyroid hormones before 8 weeks, as most of the early brain development occurs before 12th week. Until then, the fetus uses the thyroid hormones produced by the mother, and due to this, naturally the load on the thyroid gland of the mother increases as it has to produce more thyroid hormones. It is estimated that the thyroid gland has to produce approximately 50% more thyroid hormones during a pregnancy to support the extra requirement of the fetus. Now let's look at some of the risk factors for hypothyroidism. Women are at increased risk of hypothyroidism during or after pregnancy if they are over the age of 30 or have past infertility or preterm delivery, a family history of thyroid or autoimmune diseases, type 1 diabetes or other autoimmune diseases, prior radiation treatment of the head or neck, past thyroid surgeries, presence of thyroid antibodies, mainly thyroid peroxidase antibodies. You have also an increased risk of hypothyroidism if you have goiter, which is enlargement of the thyroid gland. Now let's look at treatment of hypothyroidism during a pregnancy. The treatment for hypothyroidism is thyroid hormone replacement with a form of T4 hormone called levothyroxine. This drug is the same as the T4 your body makes and is safe for pregnant females. Before pregnancy, it is important that thyroid hormones are at normal levels. If you are already receiving levothyroxine to treat hypothyroidism, you should have your thyroid hormone levels checked before you try to conceive. If your TSH levels are too high, you may need to increase your dose of levothyroxine. You should delay the pregnancy until your disease activity is well controlled. Once a hypothyroid female becomes pregnant, the levothyroxine dose often must increase. The dose should be increased as much as 30% or more in the first 4 to 6 weeks of pregnancy. After that, it is important to monitor the TSH levels, and the goal is to keep it below 2.5. Now, 2 to 5% of females have subclinical hypothyroidism during the pregnancy. Subclinical hypothyroidism is defined as increased TSH with normal concentrations of T4 and T3, which simply means that the thyroid gland is struggling to keep the thyroid hormone levels above the normal threshold levels. Since multiple studies have shown that subclinical hypothyroidism is also associated with an adverse outcome for both the mother and the offspring, most guidelines recommend that thyroxine replacement should be done in females with subclinical hypothyroidism. The main test used to detect hypothyroidism is measuring the blood levels of TSH. An elevated TSH level usually means the thyroid gland is not making enough thyroid hormone, and the pituitary gland has responded by making more TSH to try to get the thyroid hormone levels where they should be. Other blood tests include measuring T4 hormones and thyroid autoantibodies. T4 is the hormone produced directly by the thyroid gland. It is typically low in patients with hypothyroidism. Thyroid autoantibodies are seen in patients with Hashimoto's thyroiditis. When you get pregnant, TSH levels, among many other tests, are included in the basic testing profile that every female has to go through when pregnancy is detected. So, the bottom line is untreated hypothyroidism during pregnancy is associated with adverse outcomes for both the mother and the baby. Hypothyroidism during pregnancy could result in abortion, especially in early pregnancy. It can also result in recurrent pregnancy losses, anemia, preeclampsia, gestational diabetes, postpartum bleeding, and an increased risk of cesarean sections. So, it is very important to manage hypothyroidism properly during pregnancy. Make sure to watch our playlist on thyroid health, in which we have discussed about many other topics. I hope you like the video. Make sure to share with someone who you might think can benefit from this video.
I hope it was a good revision for all of us. Let's go now for the second entity or second item, hyperthyroidism during pregnancy. The hyperthyroidism during pregnancy is a different, we have a different approach in this scenario. Before we are going to more details, maybe I want to ask you this question. What is the most common cause of hyperthyroidism during pregnancy? A. Graves' disease. B. Toxic nodular goiter. C. Toxic multinodular goiter. I need your input, please, in the chat box. I will give you a few seconds. Let's revise your answers. A majority going with A. Some of you think C. Yes, Graves' disease is the correct answer. Hyperthyroidism complicating pregnancy. Again, we have overt hyperthyroidism, in which maybe you can see low TSH with high free T4 and T3, which is uncommon. Graves' disease and beta HCG mediated hyperthyroidism are the most common cause of hyperthyroidism. Beta HCG mediated, maybe it is a transient hyperthyroidism in the first half of gestation, and it is less severe generally. The Graves' disease is less severe in the later stages of the pregnancy due to a reduction in TSH receptor antibody concentration. What about examples of beta HCG mediated hyperthyroidism, gestational transient thyrotoxicosis, hyperemesis gravidarum, trophoblastic hyperthyroidism also? Let's talk about this question. Which of the following complication is expected with a pregnancy if complicated by poorly controlled hyperthyroidism? A. Heart failure. B. Renal failure. C. Hepatic failure. So what do you think is the correct answer here? I will need your input, please, before Please, I'll give you a few seconds. So let's review your answers. Majority going with A. Yes, it is the correct answer. A. Pregnancy complicated by poorly controlled hyperthyroidism complication, including spontaneous abortion, low birth weight, preeclampsia, premature labor, stillbirth, heart failure. Fetal and neonatal graves due to transplacental TSH receptor antibodies. The clue may be included in the clinical practice: fetal pulse more than 160, goiter, advanced bone age, poor growth, or cardiac failure. All fetuses of Graves' mother should be monitored for these signs. How to establish diagnosis after history and examination of the classic symptoms and signs, which is well known, like, for example, weight loss, tachycardia, tremor, sweating, diarrhea, heat intolerance. The feature distinguishing the transient hyperthyroidism of hyperemesis gravidarum from hyperthyroidism of other causes like Graves. Usually, in the transient hyperthyroidism, hyperemesis gravidarum, we find vomiting, absence of goiter, ophthalmopathy available in Graves, absence of most common symptoms and signs of hyperthyroidism, like tachycardia greater than 100 beats per minute, hyperdefecation, muscle weakness, and tremor. All of these are available or important in the clinical practice. What about laboratory? Laboratory suppressed less than, if you find suppressed TSH less than zero point 0.1 or undetectable less than 0.01 and elevated FT4, T3 that exceed the reference range for pregnancy. Look for free T4 if minimally elevated, and T3 may not be high in hyperemesis gravidarum. Free T4 and FT3 are unequivocally vocally high in hyperthyroidism from Graves. So if it is sky high, Graves is the first differential diagnosis. If it is minimally elevated and T3 may not be high in hyperemesis gravidarum, you have to think about hyperemesis. Thyroid ultrasound can help. How? In experienced hand with Doppler flow, Graves' disease, high blood flow, but with thyroiditis, you will find painless or postpartum thyroiditis, low blood flow. What about the treatment option available in these cases? Usually beta HCG mediated hyperthyroidism, transient and no need for treatment. Indication for treatment of true hyperthyroidism: yes, you have to treat symptomatic, moderate to severe Graves' disease, toxic adenoma, toxic multinodular goiter, usually TSH below 0.05 and high trimester specific free T4. Graves or nodular thyroid disease treatment are limited because of the therapy may be harmful to the fetus, but usually the target of free T4 in high normal range of for non-pregnant women using the lowest dose. This requires assessment of free T4 frequently with appropriate adjustment of medication. What about the drugs that can be used in such a case? Maybe you can use beta blocker to control the symptoms like propranolol or metoprolol. First trimester PTU then switch to methimazole or carbimazole, rye or radioactive iodine ablation, which has been discussed yesterday, is contraindicated. Thyroidectomy may be one of the options. Usually in the second trimester, you can go for it or for this option. I have video again.
Hello friends, now in the previous video we spoke about hypothyroidism in pregnancy. Let's talk about hyperthyroidism in pregnancy. The most common cause is Graves' disease, where there are thyroid stimulating autoantibodies in circulation and they drive increased production or increased stimulation of thyroid gland, leading to excess production of the thyroid hormones, a situation which we also call as thyrotoxicosis. Right now, the problem occurs when there is untreated thyrotoxicosis during pregnancy. There is increased risk of miscarriage, preeclampsia, fetal growth restriction, low birth weight, increased risk of preterm delivery, even stillbirth, and as well as increased risk of maternal heart failure with this prolonged untreated thyrotoxicosis, with excessive heart rate in the mother, tachycardia, with subsequent cardiac myopathy. There can be cardiac decompensation and increased risk of maternal heart failure also. Now, with Graves' disease, where maternal autoantibodies are present in circulation, there can be very distinct type of effects to the fetus as well, right? So the maternal autoantibodies, which are thyroid stimulating immunoglobulins, right, they can cross the placenta. Okay, these are thyroid stimulating immunoglobulins. These are autoantibodies against the TSH receptor of the stimulating type. So they can cross the placenta, reach the fetus, and they can cause stimulation of the fetal thyroid gland. So they can lead to fetal thyroid toxicosis, fetal thyroid toxicosis. And that can trigger fetal heart failure. That may trigger fetal hydrops. That may trigger stillbirth. Another kind of fetal involvement could be that the mother is on anti-thyroid drugs for treatment, and these drugs can cross the placenta and then they can cause goitrous hypothyroidism in the fetus. Right? Now, that doesn't mean that one should not treat maternal hyperthyroidism or Graves' disease with the use of anti-thyroid drugs, right? That does not mean that, because the risk is less. The risk is very less. The advantages of using the treatment are more as compared to the risks involved. And these risks are also there when we are using excess dosage. Okay, so let's say we are not titrating the TSH values and we are not titrating the dosage of the drugs during pregnancy, and we happen to give more dosage than required. We are over treating. Maybe we end up over treating, then these risks are more likely. And then the third thing that can happen is sometimes maternal TSH receptor blocking antibodies, different types of antibodies, blocking antibodies can cross the placenta and reach the fetus to cause non-goitrous fetal hypothyroidism. Right? So like I told you in thyroid physiology, that goiter happens when there is excessive TSH stimulation on the thyroid gland. Now here hypothyroidism is happening because of TSH receptor blocking antibodies which happen to reach the fetus. So there is not excess TSH, the receptor is getting blocked. So that's why non-goitrous fetal hypothyroid. Now, how will you suspect hyperthyroidism in a woman who is pregnant without any clear-cut prior history? So, your symptoms will help you. Yes. And keep in mind two important aspects of the symptoms. There is anyways tachycardia during pregnancy. But if there is tachycardia, even on waking up in the morning, that is very significant. Right? If there is failure to gain weight despite eating, despite any other obvious reason, unexplained failure to gain weight during pregnancy, you should suspect hyperthyroidism in pregnancy. Now, sometimes in women with hyperemesis, that is associated with excessive beta HCG, right, there can be clinically a state of transient hyperthyroidism. Okay, where the woman is having symptoms of hyperthyroidism like palpitations, like fatigue, or maybe like excessive increase in heart rate, right? So transient hyperthyroidism can be there at these times, and usually because it's transient, it doesn't require treatment of any kind with any drugs, except when there are symptoms plus lab confirmation. Then only one should be treating, otherwise not routinely it is required. So lab confirmation should be there. Now, there are various aspects to treatment of hyperthyroidism and Graves' disease, which you read up in medicine, endocrinology, and pharmacology. Now, to discuss all those in detail would be beyond the scope of this video. So, I will highlight the important points regarding their treatment during pregnancy. So subclinical hyperthyroidism, where there are normal T4 and T3 levels, but low serum TSH levels, that's the only problem. No treatment with drugs or anything is required. Now, when we talk about clinical hyperthyroidism, on the other hand, elevated free hormone levels and low TSH levels, then yes, of course, treatment is required. Now, regarding the treatment modalities, please remember that yes, there are various types of treatment modalities for hyperthyroidism: drugs, radioiodine, even surgery, right? So radioiodine is something that is absolutely contraindicated because it will lead to harmful effects in the fetus. Also, it will lead to fetal thyroid gland ablation also. So this is absolutely contraindicated during pregnancy. Thyroid surgery, if required, can be done for the mother in the second trimester, right? But preference is definitely given to the medical treatment first. So in the first trimester, the drug that is recommended is propyl thiouracil, PTU that we say. Okay, now please remember that outside of pregnancy, okay, methimazole is considered a better drug for treatment of hyperthyroidism. It is better at bringing control, right? And there is also hepatotoxicity associated with propyl thiouracil. So outside of pregnancy, methimazole is definitely considered a better drug. But during pregnancy, in the first trimester, propyl thiouracil is a drug of choice because methimazole is teratogenic. Okay, one specific fetal defect it is associated with is fetal aplasia cutis, a skin disorder. Okay, now in the second and third trimester, however, methimazole can be used for better control of thyroid hormone levels. Okay, and because of the hepatotoxicity associated with propyl thiouracil, many clinicians favor the use of methimazole in the second and third trimester. However, there is also no harm in continuing with propyl thiouracil in the second and third trimester as well. Okay, but please remember that in the first trimester, it's definitely propyl thiouracil and not methimazole. So these are some of the important aspects regarding treatment of hyperthyroidism during pregnancy. Now, after delivery, let's say in a breastfeeding woman, antithyroid drugs gets concentrated in the breast milk also. So if you have to use one drug in the breastfeeding mother, it should be propyl thiouracil. If the woman is breastfeeding, then the drug that is preferably propyl thiouracil. You will have to weigh the risks versus benefit, the risks of propyl thiouracil also. You'll have to see the woman's liver function tests also. But if breastfeeding is being done by the woman, preferably put propyl thiouracil, it gets less concentrated in breast milk as compared to methimazole. So that should be the preference, but one will have to weigh the risks versus benefits. So with this, I finished the video, a very basic video on hyperthyroidism in pregnancy. I hope you found this video useful.
Okay, let's go further now for the uh, how to go for monitoring of hyperthyroidism during pregnancy. And what is the goal? Persistent but mild hyperthyroidism in the mother in an attempt to prevent fetal hyperthyroidism due to drugs, since the fetal thyroid is more sensitive to the action of antithyroid drug. Overtreatment of maternal hyperthyroidism with thionamide can cause fetal goiter and primary hypothyroidism. So you have to keep it in your mind. Poorly controlled hyperthyroidism during pregnancy lead to transient central hypothyroidism due to suppression of fetal pituitary thyroid axis. This is a prescription by a doctor. Pharmacist is asking what is this, and paracetamol is the answer from the doctor. So it's encourage all of us to have a good handwriting. I think we have time to go for the next issue or topic, which is the goiter. Goiter during pregnancy is common in region where iodine intake is low. Any thyroid growth during pregnancy should be considered potentially abnormal, requiring further investigation with thyroid function and possibly thyroid ultrasound. What about nodules? A pregnant woman with thyroid nodule should be evaluated in the same way as if she was not pregnant. TSH and ultrasound should be performed. Thyroid scanning is contraindicated. Fine needle aspiration of nodule are the same as in non-pregnant patient, which was mentioned in the first day by my colleague, Dr. Humaid. FNA is safe to perform during pregnancy also. Quick question, which trimester is safest to perform surgery? First, second, or third? Please put your input in the chat box. Majority going with B, excellent. Yes, second trimester is the safest period to go for surgery. If no evidence of nodular growth by ultrasound features like extension beyond thyroid or extension adjacent to trachea or recurrent laryngeal nerve, or development of cervical lymph node during the period of observation. Many endocrinologists find needle aspiration until after pregnancy. If surgery is required during pregnancy, the optimal timing is the second trimester. If NA is performed, subsequent management depend on the biopsy. If you find benign nodule require surgery during trimester, maybe you can go for it if the patient has rapid growth or compressive symptoms. If intermediate cytology is there, like follicular neoplasm or atypia of undetermined significant, or follicular lesion of undetermined significant, maybe do molecular testing is your approach, or follow and further evaluation with molecular testing. Thyroid scan is delayed until after delivery, as most of these nodules are benign. Quickly about thyroid carcinoma, women with differentiated thyroid cancer require surgery. Thyroidectomy is usually delayed until postpartum to minimize maternal and fetal complication due to indolent nature of thyroid cancer. Surgery during pregnancy is indicated for rare patients with larger, more aggressive or rapidly growing cancer or presence of extensive nodal or distant metastasis. The safest time is the second trimester, as we mentioned. Last slide, postpartum thyroid dysfunction. Usually, the main disease is thyroiditis postpartum, characterized by transient hyperthyroidism or transient hypohyperthyroidism, followed by transient hypothyroidism, or maybe permanent. So hyper followed by hypo may be followed by euthyroid, or hypothyroidism may be continue to have levothyroxine replacement. Only mild symptoms during the hyperthyroidism phase do not require any treatment. You can use beta blocker to relieve symptoms in breastfeeding women. Propranolol is used because of the lowest transfer into milk. No role for anti-thyroid drug. During hypothyroid phase of postpartum thyroiditis, symptomatic with TSH above normal range require treatment with levothyroxine. But if the patient is asymptomatic with TSH above 10, also you give the replacement. But if it is not in these two indications, no need for replacement. Most women recover and usually euthyroid after 1 year. Graves' disease, women may develop Graves' disease postpartum or experience exacerbation. In addition, women in remission after antithyroid drug therapy have a higher incidence of relapse during postpartum period than at times related to pregnancy. Take-home message: the evaluation and treatment of pregnant women with thyroid disease parallel that of non-pregnant women and men, but present some unique problems. Reminder for Twitter account, if you are interested to see more knowledge and update in endocrinology and diabetes, please follow our Twitter account, EndoDMOS, ENDO DMOS. It's time now for break. We'll come back at 5 p.m. sharp, inshallah. يعطيكم العافية. Welcome again, and we'll proceed in this session to autoimmune polyglandular syndrome, including this case study. I'll present one of the scenarios in the clinical practice that I faced, and then I will give a brief about how there are correlations between thyroid autoimmune diseases and polyglandular syndrome. In the world, I have seen our endocrine team was consulted to see a 35-year-old Indian man who is known case of hyperthyroidism. He was admitted through emergency room with anemia. He was admitted yesterday or the night before the call with a history of palpitation dizziness for about 1 month. He was diagnosed 6 months back with hyperthyroidism and started on carbimazole by the medical team. At that time, he was presented with heat intolerance, weight loss, and neck mass. He lost follow-up and used carbimazole only for 1 month because of poor compliance. Carbimazole dose initially given was 10 milligram TID. Also, he was given enteral 20 milligram TID. There was no family history of thyroid disease on examination. The positive finding including he was conscious oriented, of course, blood pressure was maintained, pulse regular but tachycardic 120, temperature 37, he was pale with eye proptosis and he has diffuse goiter. The laboratory results shows the following. TSH 6 months back was 0.005 and today 0.005. Free T4 6 months back was 100 and today 88. Free T3 was 12 6 months back and today is 10. So there was no difference in the last 6 months because of the poor compliance. What about chemistry? 6 months back and today we have liver function test as follows: ALT 48 and 50, AST 55 53, fasting glucose 90 99, serum sodium 136 138, calcium about 9 milligram per deciliter, and creatinine was normal almost. And WBC 6 months back was 4,500 and today 3,000. Hemoglobin 10 and today 6.6. So there is a significant drop in hemoglobin. Platelets 190 and today no 290. Absolute neutrophilic count 1,600 and today 1,100. MCV and MCH both are normal. So to minimize or to summarize, patient has hyperthyroidism and now he has anemia. What is most likely cause of this hyperthyroidism? What do you think? So I want you to share your opinion down in the chat box. A, toxic nodule. B, toxic multinodular goiter. C, Graves' disease. D, subacute thyroiditis. The last choice, sorry, by mistake, it is D, not C. So toxic nodule, toxic nodular goiter, Graves, subacute thyroiditis. What is your opinion? Okay, let us review your answers. Majority going with C. Yes, C is the correct answer. Why? Let us see together. Graves' disease because it is autoimmune hyperthyroidism. What is the relation with the anemia and this autoimmune? Well, let us see together. What did we do? We asked for further lab tests, including iron study, occult blood, and endoscopy was planned. And anti-TSH receptor was requested. Antibodies, I mean, thyroid uptake appointment was given after 10 days, and peripheral blood film shows the following. You see this abnormal cells. And this abnormal neutrophils, it is called hypersegmented neutrophils. Packed RBC transfusion arranged 2 units transfused, enteral dose increased to control the rate to 40 milligram twice a day, carbimazole resumed with the same dose. 2 days after hospitalization, hemoglobin improved to 9, heart rate came down to 88, he was discharged and was given appointment in hematology clinic after 2 weeks to follow the labs, endocrine appointment given after 2 weeks to follow uptake results. And discharge treatment was 10 milligram of carbimazole TID with Inderal 40 milligram BID. Unfortunately, patient he did not follow the in the clinic and presented to ER after 2 months with anemia again. What is the scenario now in the second hospitalization? This time blood work was taken, then packed RBC given, B12 iron TIBC thyroid function test was also ordered, carbimazole Inderal resumed because again he was not compliant. He reported better compliance to medication during the last 2 months, but not the compliance that is needed. Next day, results shows hemoglobin 9.1, B12 was low, 3T4 was 25, FT4 was 6, TSH 0.005, WBC total was 1,500, absolute neutrophilic count was 400. So we are seeing here that B12 is low. So because of B12 was low, B12 injection is arranged and given. Inderal continued carbimazole was stopped immediately. We'll explain later. Review of uptake and TSH gave impression of Graves' disease. Uptake was going with Graves, and TSH was positive, so Graves' disease was diagnosed. RI ablation was arranged after 1 week. Question here. Before you initiate carbimazole, you have to look for what? This is, I think, mentioned before, but I want your input, please. A, renal function test plus serum sodium. B, liver transaminase and white blood cell. C, platelets and calcium. Let us review your answers. B, A, B, B. Majority going with B, yes. Majority are correct. Liver transaminase and white blood cells. So discussion and highlights on the scenario. Fortunately, he is euthyroid last presentation and was sent for radioactive iodine ablation. In this situation, thionamide is contraindicated. Why? This is from American Thyroid Association. Prior to initiating thionamide, usually WBC should be measured. Thionamide in patient with a baseline absolute neutrophilic count less than 1,000 or elevated liver transaminase more than 5,000, don't initiate carbimazole. From the ACE, hyperthyroidism and other causes of thyrotoxicosis, if absolute neutrophilic count less than 500 and the liver transaminase more than 5 fold, don't initiate carbimazole. What should we do in monitoring? We do not routinely monitor white blood cell, but as we mentioned before, you have to follow the clinical scenario. If the patient develop fever, upper respiratory tract, you have to measure the WBC. And if the patient develop, for example, jaundice, maybe you can look for liver function test as a monitoring. Report of agranulocytosis are more common with BTO, propylthiouracil, than carbimazole. Most cases occur within 3 months after treatment is begun. Recovery from agranulocytosis usually takes a few days but can be prolonged, and morbidity and death from serious infection can occur. What about granulocyte colony stimulating factor? One of the options, yes, available to give patient adjuvant therapy in severe cases to raise up the WBC. There is no firm evidence that such therapy impact mortality from antithyroid drug. What about the megaloblastic anemia? Megaloblastic anemia, usually we have in the peripheral blood smear this hypersegmented neutrophils. Classically, it is pathognomonic for it. One of important causes of megaloblastic anemia is pernicious anemia. So this patient has a pernicious anemia manifested by B12 deficiency. Pernicious anemia is an autoimmune condition that prevents formation of the vitamin B12 complex, which in turn dramatically decrease vitamin B12 absorption. Pernicious anemia is often associated with additional autoimmune condition and or additional autoantibodies. Polyglandular autoimmune syndrome type 2, a generalized autoimmune disorder characterized by autoimmune thyroid disease, adrenal insufficiency, type 1 diabetes, autoimmune non-endocrine symptoms like vitiligo. So this is the polyglandular syndrome. We have two types. Major, we can say the common one, type 1 and type 2. And we are talking here about type 2. Why? Because we have autoimmune thyroid disease manifested with gravis, and we have pernicious anemia. So in this particular patient, we suspect polyglandular autoimmune syndrome. Why? As I told you, autoimmune diseases come together. Other diseases that may be seen, including adrenal insufficiency, type 1 diabetes, alopecia, myasthenia gravis, Sjogren's syndrome, etc. In type 1, we have two diseases that usually not come in type 2, including hypoparathyroidism and chronic cutaneous candidiasis. These two disorders only comes in type 1, but the others like adrenal, as you can see here, insufficiency, type 1 diabetes may occur in both type 1 and type 2, but mucocutaneous candidiasis and hypopara occurs only in type 1. I'm done with this topic, and then we'll go immediately to the next one. One of important topics related to thyroid disorders are thyroid carcinomas, and we'll talk about some of carcinomas in the thyroid. I will start with medullary thyroid carcinoma. Usually medullary thyroid carcinoma definition, it is defined as neuroendocrine tumor of parafollicular or C cells of thyroid gland. It accounts for approximately 1 to 2% of thyroid carcinoma. The production of calcitonin is characteristic feature of this tumor. Most cases are sporadic. A solitary thyroid nodule is the most common presentation of sporadic medullary thyroid cancer. In most patients, the disease has already metastasized at the time of diagnosis. Basal serum calcitonin concentration usually correlate with tumor mass, but also reflect tumor differentiation, and they are almost always high in patients with palpable tumor. What about the diagnosis? Diagnosis of sporadic medullary thyroid cancer is usually made after fine needle aspiration biopsy in a patient who has solitary thyroid nodule. Sensitivity of FNA is improved by addition of immunohistochemical staining for calcitonin, the routine use of serum calcitonin screening to complement FNA in the routine diagnosis of thyroid nodule is controversial in the United States. What about evaluation? For patient diagnosed with MTC or medullary thyroid cancer on the basis of cytological evaluation of a thyroid nodule, evaluation include biochemical, radiological, and genetic testing is very important. Serum calcitonin and CEA, which is carcinoembryonic antigen, are very crucial. These tests can establish that the tumor is capable of hypersecreting hormones. The value can be compared with post-operative value. Post-operatively, results may provide a prognostic factor or indicate biochemical cure. Radiological evaluation: when MTC is diagnosed by fine needle aspiration biopsy, ultrasonography of the neck is indicated to look for cervical lymph node involvement. For patients with local lymph node metastasis on ultrasound, or with preoperative serum basal calcitonin more than 500, additional imaging is required to assess the metastatic disease. Genetic testing for germline RIT mutation. Some patients with apparently sporadic MTC have unsuspected germline RIT mutation and therefore heritable disease suspected. We usually, it is recommended to go for RIT testing, very important in such a case. Testing for coexisting tumor, sometimes given the possibility that any patient with MTC may have multiple endocrine neoplasia type 2. If results of germline RIT testing are unknown, preoperative testing must also include measurement of serum calcium to rule out hyperparathyroidism requiring concomitant surgical intervention, and testing for pheochromocytoma. Suggest plasma fractionated metanephrine as the initial screen for pheochromocytoma is essential. Staging: initial staging is based upon tumor size and presence or absence of extrathyroidal invasion, local and regional nodal metastasis, and distant mets. Dynamic risk stratification for MTC allows clinicians to modify initial staging risk estimate over time based on the biological behavior of the tumor. What about management? For patient newly diagnosed MTC or medullary thyroid carcinoma, preoperative evaluation should include measurement of serum calcitonin, carcinoembryonic antigen, ultrasonography of the neck, genetic testing for germline RIT mutation, and all patients who have either unknown RIT mutation status or germline RIT mutation, biochemical evaluation for coexisting tumor, especially pheochromocytoma. For patients with local lymph node metastasis on ultrasound or with preoperative serum basal calcitonin more than 500, additional imaging is required to assess metastatic disease. For patients with sporadic MTC, usually it is recommended to go for total thyroidectomy rather than lobectomy as initial therapy. Thyroxine therapy should be started immediately after surgery. The goal of TF therapy is to restore and maintain euthyroid. Suppression of serum thyroid stimulating hormone is not indicated in patients with MTC as in PTC, papillary thyroid cancer, which is the coming topic. Because C cells are not TSH responsive, that's why it is not your goal. Similarly, adjuvant therapy with radioiodine is not indicated because the tumor cells do not concentrate iodine. Serum calcitonin and CEA should be measured 2 to 3 months after surgery to detect the presence of residual disease. For patients with undetectable post-operative calcitonin level, we measure serum calcitonin and CEA level twice yearly for 2 years, and then yearly if values are stable. Usually, ultrasound of the neck done 6 to 12 months post-operative to establish a baseline. Serial ultrasound evaluation not required in patient with undetectable post-operative calcitonin level. For patients with persistent hypercalcitonemia, a further evaluation depends upon magnitude of the elevation in the serum calcitonin concentration and the calcitonin and CAA doubling time. Patients with post-operative calcitonin level that are detectable but less than 150 should have neck imaging like ultrasound with or without CT or MRI to identify persistent leukoregional disease. Patients with post-operative calcitonin level that are more than 150 should undergo additional imaging like CT, MRI, neck, chest, and abdomen bone scan or bone MRI in patients suspecting of having skeletal mets to identify possible distant metastases. Treatment options for patients with recurrent residual disease include observation, active surveillance, surgical resection, external beam radiation therapy, and other directed therapy, or systemic therapy, like, for example, this therapy depends on clinical factors. Uh, For patients with MTC confined to the neck and no evidence of involved cervical lymph node on preoperative ultrasound, usually routine perform bilateral dissection of central lymph node compartment without prophylactic lateral neck dissection. For patients with evidence of central cervical lymph node involvement, dissection of the involved lateral neck compartment is also performed. For patients with locally advanced or metastatic disease, total thyroidectomy with resection of involved lymph node compartment is performed in most patients. However, since the goal of surgery are largely reparative in this setting, a less aggressive approach to both primary tumor and local regional metastases may be warranted. I am done with medullary, but the most important is to go for papillary thyroid carcinoma, which is the next topic. Please stay with us. I will share it immediately. The most important, as I told you, is the differentiated thyroid carcinoma, which include papillary thyroid cancer, which is actually the most common type of thyroid carcinoma. Surgery is the primary mode of therapy for patients with differentiated thyroid cancer. It should be after surgery followed by radioactive iodine therapy. If the patient has high risk or categorized as high risk, and thyroid hormone suppression therapy should be given in all cases, but the goal of TSH may be different from patient to another. After initial surgery, patients with thyroid cancer are typically managed with endocrinologists who are specialized in the treatment of thyroid carcinoma. In this topic, we'll try go to therapeutic approach, how to deal with differentiated thyroid cancer. The thyroid, or classification, thyroid follicular epithelial derived cancer, are divided into three categories. Number one, papillary cancer, which is the most common, 85%, follicular cancer, 12%, anaplastic undifferentiated cancer, less than 3%. Papillary and follicular cancers are considered differentiated cancer, and patients with these tumors are often treated similarly despite numerous biological differences. Most anaplastic cancer appear to arise from differentiated cancer. The treatment of anaplastic thyroid cancer is reviewed separately. Other malignant disease of thyroid include medullary thyroid cancer, as I told you before, including maybe it is a part of multiple endocrine neoplasia. What is about surgical management of differentiated thyroid carcinoma? Surgery is the primary mode of therapy, as we mentioned, in any differentiated thyroid cancer, and preoperative ultrasound is important for planning the surgical procedure. In the absence of prospective trial, conclusion regarding the optimal surgical approach are based upon retrospective analysis and expert consensus opinion. After initial therapy, patients with thyroid cancer are typically managed by endocrines, as we mentioned. Preoperative imaging. All patients should have preoperative ultrasound. So what is the diagnostic imaging test that should be done? It is ultrasound of the central and lateral neck lymph node as well, in order to plan the best surgical procedure. Additional imaging beyond routine preoperative neck ultrasound may be sometimes needed or ordered by the doctor. What is the type of surgery or choice of the surgery? Surgery is the primary mode of therapy, as we mentioned, but surgery should be performed by an expert surgeon to minimize the risk of hypoparathyroidism and recurrent laryngeal nerve injury. In one study, complications were lower when surgery was performed by a surgeon performing at least 25 thyroidectomies per year. The operative approach depends upon the extent of the disease, for example, primary tumor size and the presence of extrathyroidal extension or lymph node mets, the patient age and presence of comorbidities conditions all are playing a role in this case. The choice of procedure is discussed as the following. If the tumor size less than 1 centimeter without extrathyroidal extension and low lymph node, surgery is planned for unilateral intrathyroidal differentiated thyroid cancer less than 1 centimeter. Thyroid lobectomy is the preferred approach, unless there are clear indication to remove the contralateral lobe. For example, clinically evident thyroid cancer in the contralateral lobe, previous history of head and neck radiation, strong family history of thyroid cancer, imaging abnormalities that will make follow-up difficult. If the tumor between 1 to 4 centimeter without extrathyroidal extension and no lymph node, for intrathyroidal tumor between 1 and 4 centimeter, the initial surgical procedure can either be total thyroidectomy or thyroid lobectomy. Total thyroidectomy would be chosen either based on patient preference, presence of ultrasonographic abnormalities in the contralateral lobe, nodule thyroiditis in the contralateral lobe, or non-specific lymphadenopathy that will make follow-up difficult, or on a decision by treatment team that radioiodine therapy may be beneficial either as adjuvant therapy or to facilitate follow-up. Tumor more than 4 centimeter, extrathyroidal extension or metastasis, total thyroidectomy is recommended if the primary tumor is 4 centimeter in diameter or greater, there is extrathyroidal extension of the tumor, and there are metastases to lymph node or distant sites. If any tumor size and history of childhood head and neck radiation, total thyroidectomy should be also performed in all patients with thyroid cancer who have history of exposure to ionizing radiation of the head and neck, given the high rate tumor recurrence with lesser operation in these patients. Multifocal papillary microcarcinoma, fewer than 5 foci, unilateral lobectomy and ischectomy is an appropriate procedure for patients whose pathology report subsequently show multifocal papillary microcarcinoma with fewer than 5 foci. Multiple or multifocal papillary microcarcinoma more than 5 foci when multifocal papillary cancer is appreciated pre-operative, particularly when a large number of microcarcinoma are suspected, for example, greater than 5 foci, especially if the foci are in the 8 to 9 millimeter size range. More likely, total thyroidectomy is the preferred option. For patient whose initial procedure was a lobectomy and in whom pathology shows multifocal papillary microcarcinoma with more than 5 foci, especially in the foci, if the foci are in the 8 to 9 range, typically completion of thyroidectomy is preferred. What about post-operative complication? Usually management of hypoparathyroidism and recurrent laryngeal nerve injury may be seen in these cases, and it is not the scope of our revision here. Post-operative thyroid hormone. Usually, if the patient had lobectomy, for low and intermediate risk patient whose initial surgery was lobectomy, usually 3T4 may be delayed and no need for immediate post-operatively should be given. TSH can be measured 6 weeks after surgery and determine the need for T4 based upon TSH and evaluation of post-operative disease status. TSH between 0.5 and 2 is your goal in low-risk patient. What about total thyroidectomy? Of course, after total thyroidectomy, all patients require post-operative thyroid hormone therapy to replace normal hormone production and to suppress regrowth of the tumor. The initial dose and type of thyroid hormone depend upon the likelihood of needing radioiodine scanning ablation and the method of preparation for radioiodine scan. These decisions are based upon estimated risk of persistent or recurrent disease in the immediate post-operative period. Complete clinical pathological finding may be unavailable to fully estimate this risk, and clinician may need to modify dosing 4 to 6 weeks post-operative. T4 usually started 1.6 to 2 microgram per kg per day can be started immediately post-operatively in the following patient. 1. American Thyroid Association, low and intermediate risk who are unlikely to need radioiodine scanning or ablation. Selected ATA intermediate and high risk patient in whom radioiodine scanning and ablation will be done using recombinant human TSH. The higher doses are used in selected intermediate and high risk patient modified by age and other comorbid conditions. TSH is measured 4 to 6 weeks post-operatively. And the dose is adjusted as needed to achieve goal TSH. The initial TSH goal is based upon the risk of recurrence as determined by clinical pathological finding and post-operative thyroglobulin. So it is essential and crucial to measure thyroglobulin, especially in high-risk patient, to know if there is regrowth of the tumor or no. The long-term TSH goal depends upon structural and biochemical response to initial therapy, which is determined by ongoing assessment and risk stratification. For patients in whom radioiodine scanning and ablation will be done using thyroid hormone withdrawal, short-term thyroid hormone replacement can be initiated post-operative with T3 25 mcg 2 to 3 times daily. After 2 to 3 weeks, T3 is discontinued and imaging is performed once the patient's serum TSH above 25 to 30. Another alternative is simply to withhold thyroid hormone till TSH reaches 30, and this is usually the practice what we are using. Initial risk stratification, we mentioned before that maybe you are seeing low or intermediate or high risk. After surgery, the presence or absence of persistent disease and risk of recurrent disease should be assessed in order to determine the need for additional treatment, in particular radioiodine therapy. The post-operative operation, typically TSH should be measured with non-stimulated thyroglobulin level in the blood approximately 4 to 6 weeks after thyroidectomy or lobectomy in order to have a better define the post-operative disease status. While TATA guidelines going with the optimal cut-off value for either stimulated and non-stimulated TG 4 to 6 weeks. Usually we are depending on non-stimulated TG as the following. Number one, if it is less than 5 nanogram after total thyroidectomy, less than 30 nanogram after thyroid lobectomy, serum TG value above these cut-off should promote re-evaluation of the completeness of initial surgery, maybe need to redo the surgery. Usually with neck ultrasound and consideration of possibility of persistent metastatic disease. Diagnostic whole body scan for localization of persistent disease before remnant ablation, adjuvant radioiodine therapy or radioiodine treatment of metastatic thyroid carcinoma are performed less often. They can be performed when and the extent of residual disease cannot be determined from surgery and neck ultrasonography, and when the presence of residual disease may alter the decision to treat with radioiodine or administrated activity. Because almost all patients have thyroid remnant, the approach is to omit the pre-iodine treatment diagnostic scan, administer empiric therapeutic doses of iodine therapy based upon surgical and ultrasound finding, and we can obtain only a post-radioiodine scan for localization of uptake. What about risk classification? Usually, as we mentioned, we have low, intermediate, and high risk, usually depending on the size. Sorry. What about staging? The staging, formal disease staging, is based upon the applying the individual TNM description in the American Joint Commission of Cancer. ATA risk stratification system to estimate the risk of persistent or recurrent disease. This system is designed to stratify patients as having either low papillary cancer, intermediate. What does it mean? Intermediate and low. Low means papillary thyroid carcinoma that is confined only to thyroid. What about intermediate? Intermediate, there is involvement of regional metastasis or some histology, extrathyroidal extension, or vascular invasion. But high risk include gross extrathyroidal extension, distant metastasis, post-operative serum, TG suggestive of distant mets also. Risk of recurrence primarily based upon clinical pathological finding. The risk of recurrence, however, follow a continuum across the three discrete risk categories: low, intermediate, and high. Additional prognostic variable, like for example, extent of lymph node involvement, degree of vascular invasion in follicular thyroid cancer, were included in a modified version of risk stratification. Serum-specific molecular profile like TERT and BRAF may be used to detect risk of extrathyroidal extension, lymph node metastasis, and even distant metastasis. While these observations need further validation, it is likely that a specific molecular profile of primary tumor may have significant prognostic value that could be incorporated into stratification system. The subsequent management based on risk stratification, as we mentioned, post-operative management include treatment with thyroid hormone, suppressive therapy to suppress TSH in most of the patient, and radioiodine high-risk patient, and selected intermediate risk patient to ablate any remnant thyroid tissue available. Post-operative management depend upon the risk of recurrence and persistent disease. Thyroid hormone suppression also after initial thyroidectomy, whether or not radioiodine therapy is administered, levothyroxine is required in most patients to prevent hypothyroidism and to minimize potential TSH stimulation of tumor growth, which was described a lot yesterday. Our approach for initial thyroid hormone suppression depend on the risk. If the patient with low risk, usually for patients with low risk disease treated with thyroidectomy who have detectable serum TG level, the serum TSH initially can be maintained between 0.1 and zero point 0.5. For similar patients who have undetectable serum TG level or with or without remnant ablation or who were treated with lobectomy, TSH can be maintained in mid to lower half of reference range. So our target in a low risk patient, usually TSH between 0.5 up to 2. In the latter setting, thyroid hormone treatment may be unnecessary if the patient can maintain their TSH in this range. ATA intermediate risk, usually TSH goal between 0.1 to 0.5. But if the patient with high risk serum TSH initially should be less than 0.1. So TSH goal according to the risk. The TSH goal for long-term follow-up are based on response to therapy assessment, further modified by comorbid conditions that increase the potential risks for prolonged TSH suppression. The dose also may be decreased to allow TSH to rise into normal range in intermediate risk patients who demonstrate an excellent response to therapy. The hypothesis that reduction of serum TSH to below normal range decrease morbidity and mortality in all patients with differentiated thyroid cancer has not been proven, but some retrospective studies suggested improve relapse-free survival when serum TSH concentration were undetectable during follow-up. In the follow-up report, a moderate degree of TSH suppression was associated with improved overall and disease-free survival in all stages, even in those with distant mets. There was no additional survival benefit with aggressive TSH suppression. In a randomized trial of suppressive versus replacement therapy, in more than 400 patients, Japanese with papillary thyroid cancer achieved mean TSH level of 0.07 and 3.19 respectively. Disease-free 5-year survival recurrence rate and site of recurrence were not significantly different between these two groups. However, these data might not be generalizable since the majority of participants has lobectomies and prophylactic central neck dissection. And some had prophylactic lateral neck dissection, forms of surgery generally not done in most Western countries. These findings combined with a risk of overly aggressive T4 therapy including the potential for acceleration of bone loss, atrial fibrillation, and cardiac dysfunction. Emphasizes the importance of tolerating T4 dose to the extent of disease and the likelihood of recurrence. This decision can be based in part upon staging by tumor node MITS system in conjunction with proposed ATA risk of recurrence system. What about radioiodine therapy? It is administered after thyroidectomy in patients with differentiated thyroid cancer to ablate residual normal thyroid tissue, remnant ablation, provide adjuvant therapy of subclinical micrometastasis disease, and or provide treatment for clinically apparent residual metastatic thyroid cancer. The decision to treat with radioiodine depends upon the risk of recurrence persistent disease. Usually administration of radioiodine after total thyroidectomy in high-risk patient and in selected intermediate risk patient, depending upon specific tumor characteristic. As we mentioned, clinical lymph node metastasis outside thyroid or other high-risk features. ATA low risk in absence of a proven benefit on either disease-free survival or recurrence, usually a radioactive iodine ablation for remnant with low risk, no need to be given, especially if there is only less than 1 centimeter foci or multiple foci, all of them less than 1 centimeter in absence of high-risk features, even in the presence of a small volume regional lymph node metastasis, less than 5 lymph node measuring less than 2 millimeter. ATA, intermediate risk disease, usually in this category, post-operative radioiodine ablation to selected intermediate risk patients, including those with clinically significant lymph node mets outside of the thyroid bed, vascular invasion, or more aggressive histological subtypes, such as tall cell, columnar cell, insular, or poorly differentiated histologies. ATA, high-risk disease, usually radioiodine ablation is recommended, including patients with distant metastasis, macroscopic tumor invasion, and or incomplete tumor resection with gross residual disease. Monitoring of the response of therapy, monitoring strategy based upon the patient American ATA or American Thyroid Association. The strategy is in keeping with ATA guidelines, usually dynamic risk stratification with initial strategy. As I mentioned before, it is important to recognize that initial risk estimate may need to change as new data are accumulated. As originally convinced, these clinical outcomes describe the best response to initial therapy during the first 2 years of follow-up, but are now being used to describe the clinical status at any point during follow-up. What are the outcomes expected? Number one, excellent response, no clinical, biochemical, or structural evidence of disease. Number two, biochemical incomplete response, abnormal TG or rising TG antibody value in absence of localized disease. Number three, structure incomplete response, persistent or newly identified local, regional, or distant myths. Finally, intermediate response, no specific biochemical or structural finding that cannot be confidently classified as either benign or malignant. This includes patients with stable or declining anti-thyroglobulin antibody level without definitive structural evidence of disease. Initial monitoring during first year, including detection of possible persistent recurrent of the disease, monitoring of neck ultrasound, TSH, serum TG level on thyroid suppression, TG on thyroid hormone suppression, generally measured every 3 to 6 months for the first year, with ultrasound at 6 to 12 months interval, depending on initial risk. Thyroglobulin measurement are used to monitor patients with differentiated thyroid cancer for persistent or recurrent disease after initial therapy, lobectomy, thyroidectomy with or without radioiodine ablation. In the first year after treatment of differentiated thyroid cancer, measurement of thyroid hormone suppressed TG and TG antibody every 3 to 6 months is recommended. Serial TG measurement should be performed using the same assay. Anti-TG antibodies present initially in approximately 25% of patients with thyroid cancer interfere with all assay of TG. As a result, usually we have to measure anti-TG using the same assay over time with each measurement of serum TG. TG assay are reviewed later on, but it's not the scope of our topic here. Serum TG can be measured while taking suppressive doses of thyroid hormone or with TSH stimulation. Stimulated TG measurements are generally not necessary in ATA low-risk patients who do not receive radioiodine to ablate thyroid remnant, or in ATA intermediate high-risk patients who have detectable TG on suppression. Stimulated TG value are useful in ATA intermediate and high-risk patients with an undetectable suppressed TG to document an excellent response to therapy, or conversely to identify presence of persistent recurrent disease. In newer, more sensitive TG assay, serum TG concentration correlate with RHTSH simulated TG concentration and therefore may decrease the need of RHTSH stimulated measurement. Interpretation, thyroidectomy with RI ablation for patients who had total thyroidectomy and radioiodine remnant ablation, excellent response is TG less than 0.2. Thyroidectomy without RI ablation, usually an excellent response, non-stimulated TG less than 0.2. Many patients do have undetectable basal TG level less than 0.2, and basal serum TG should be measured in such patients as rising value over time are suspicious for growth thyroid tissue or cancer. Lobectomy, periodic measurement of serum TG should also be performed, and who treated with lobectomy, although specific criteria is not there. An excellent response should have a serum of TG less than 30. Thyroglobulin antibodies, as we mentioned, should be done or measured. Imaging, neck ultrasound performed if it takes 6 to 12 months interval to see if there is any recurrence. The most common place for recurrence is cervical lymph node. It may be characteristic of cystic appearance, microcalcification, loss of normal fatty hilum, and peripheral vascularization. Whole body scan, if you are suspecting, for example, metastasis, maybe you can use it. After 1 year, follow-up neck ultrasound, serum TG is guided by assessment of involved patient response to therapy. Most recurrence of differentiated thyroid cancer occur in the first 5 years after initial treatment, but recurrence may occur many years or even decade later. Nonetheless, continued routine use of surveillance ultrasound is recommended in ATA low to intermediate risk patient with no biochemical or clinical evidence of disease, more likely to identify false positive finding. TSH measured annually and 6 to 8 weeks after any dose adjustment. We mentioned this in low risk. You have to keep your patient in the lower part of TSH, in higher TSH goal, and TSH goal is going down if the patient is intermediate, and more going down if it is high risk. Management of persistent or recurrence, if the patient depending on tumor size, tumor location, tumor growth rate, symptoms and patient preferences, and measurement of TG concentration also play a role. Using CT and MRI also has a role. Many patients still have abnormal serum TG, so surgical resection is typically reserved for patients with clinically significant low volume metastatic disease, for example, central neck lymph node, at least 1.5 to 2 centimeter, especially if there are increasing in the size dimension. Finally, what about the prognosis? This is the last slide. Most patients with papillary cancer do not die of their disease. However, a number of factors have been identified that are associated with higher risk of tumor recurrence and cancer-related mortality. The most important prognostic factor are age at diagnosis, size of primary tumor, and presence of soft tissue invasion or distant mets. When compared with papillary thyroid cancer, follicular cancer typically occur in older population. Women may have a better prognosis than men. I'm done with this topic. I'm done with my part of today lectures. Thanks for your listening. It's the time now to thanks also organizers and to leave you for a break for about half an hour. We'll resume 6:30 with my colleague Dr. Humaid Al-Sahafi to complete the course. Hopefully, or hope to see you again, inshallah, in another course soon. Assalamu alaikum wa rahmatullah.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. Welcome our audience. I want to thank you for being with us for the last session today. For the last three lecture, I will complete which Dr. Bender started today, the third day of this comprehensive course of thyroid disorder. Lecture today about now about thyroidectomy, which is the common procedure done for the thyroid gland. It's indicated. We'll talk about the indication and when the thyroidectomy is advised for thyroid patients. Thyroidectomy, thyroid surgery, is a surgical technique for which part of the thyroid removed or total thyroidectomy done, or any lobectomy done for a patient. It's indicated for some patients. It's under general anesthesia, either for the removal half of the thyroid or subtotal thyroidectomy or total thyroidectomy. The indication, as we know, the most top indication for thyroidectomy or total thyroidectomy is thyroid cancer. If the patient has thyroid cancer, if the invasive thyroid cancer or large tumor, the indication is total thyroidectomy. But in micro cancer, lobectomy is enough as a standard treatment for thyroid cancer. And after the thyroid cancer removal for total thyroidectomy, some patient with advanced thyroid cancer, they need radioactive iodine ablation. In patient with low risk biopsy proven papillary thyroid cancer and medullary thyroid cancer, and thyroidectomy is indicated. Patient with fine needle also for Hurther cell tumor, which has high risk for tumor. This pathology is the thyroidectomy also. Total thyroidectomy is indicated. So thyroid tumor, thyroid cancer, any form of cancer, papillary, medullary, anaplastic, or Hurther cell tumor or follicular carcinoma, the total thyroidectomy is indicated, except if there is micro tumor, this need to do lobectomy. Other indication, failure of the medical treatment for hyperthyroidism, like Graves' disease or multinodular goiter. This is indicated, another indication for total thyroidectomy. Another indication for total thyroidectomy or subtotal thyroidectomy is compressive symptom of the large goiter, which compresses the adjacent structure like trachea and esophagus, causing dyspnea or dysphagia, or disfiguring the patient and make any social problem for the patient. If patient ask for it, we can this is the type of indication for one indication for total thyroidectomy. So the contraindication for thyroidectomy is pregnancy. Pregnancy is a contraindication, especially first and last trimester. If the patient indicated for thyroidectomy or any thyroid surgery, the suitable time is the second trimester. And if the patient is still hyperthyroid, the patient needs to be prepared for thyroid surgery. After the patient stabilizes and patient euthyroid, he can easily go for thyroidectomy. Thyroidectomy in patient with hyperthyroid is risk for thyroid storm with the serious complication. So the contraindication is pregnancy, especially first and third trimester, and the other contraindication if the patient has hyperthyroidism and he is in thyrotoxic phase, they should stabilize and be euthyroid, then they can go for total thyroidectomy. Preoperative workup, as thyroid patients, we usually do a thyroid function test to make sure the patient is not hyperthyroid or toxic. And we'll do the other investigation like ultrasound, and if there is any nodule, we'll go for FNA, fine needle aspiration biopsy, to discover which tumor we are dealing with. If the patient high risk, if the tumor is high risk, the total thyroidectomy is indicated. And if the patient the tumor is large, we'll do the CT scan to know the extrathyroidal extension of the tumor or any nodule, lymph nodes. This is the part of the evaluation before the surgery. Also, we'll do the calcium profile and electrolytes. Some patient after thyroid surgery, they go for hypocalcemia secondary to manipulation and ischemia of the parathyroid gland. Calcitonin, serum calcitonin as the basal investigation for medullary thyroid cancer can be indicated in patient with for medullary thyroid cancer. Anesthesia, the usual, the total thyroidectomy underwent under general anesthesia with endotracheal intubation. Positioning, the patient should place supine position and the arm is extended to make a good field for thyroid surgery, and a shoulder rod and gel pad should be placed behind the patient to make the good field for surgery. We should mark the site of surgery and the following key anatomic location by expert thyroid surgery to be located: thyroid notch, cricoid cartilage, superior edge of the clavicles, and sternal notch. Intraoperative nerve monitoring, because as we said before, thyroid is behind the thyroid there is important structure like the recurrent laryngeal nerve, and also which are responsible for focal cord supply. The interoperative nerve monitoring is important to evaluate recurrent laryngeal nerve to be sure not injured during the surgery. The use of recurrent laryngeal nerve monitoring has been described since 1970s, has evolved from the intramuscular electrode to the currently used endotracheal tube, which are integrated surface electrode that contact the vocal cord to evaluate any touch of the recurrent laryngeal nerve during the surgery. Technique of the thyroidectomy, the technique described referred to the capsular dissection of the thyroid lobe, which can be extended, and total thyroidectomy prior to the advent or capsule dissection. The literature described the use of nodulectomies, which resection subtotal thyroidectomy to treat thyroid nodule and thyroid cancer. Incision exposure of the thyroid gland. This is how the thyroid looked in the thyroid surgery after removal of the skin and the capsule. Releasing the cerebral ball. Once the thyroid gland is identified, attention should be turned to the single lobe using the retractor, and dissection, capsule dissection should be carried to the lateral aspect of the thyroid lobe. And once the lateral border of the dissection has been performed, the carotid artery identified, blunt dissection may be carried out superiorly. The identify the parathyroid gland during the thyroid surgery. The surgeon should identify the parathyroid gland to avoid their dissection. and removal with the thyroid, because if they remove the patient who had permanent hypoparathyroidism, and patient needs vitamin D and calcium replacement. This is during the surgery, during the removal of thyroid and identification of the parathyroid gland. Identify, and I also we should identify the recurrent laryngeal nerve described in the anatomy section. Slight variation in the anatomy and location of the recurrent laryngeal nerve can exist, because we should evaluate the recurrent laryngeal nerve. It's different anatomy in different patients. Removing the thyroid gland after identifying the stimulate, stimulating the recurrent laryngeal nerve, the thyroid gland can be removed. Very ligament defined the posterior lateral attachment of the thyroid gland. Immediate post-operative course. The author practice patient who had undergo to thyroidectomy remain overnight for around 1 day after the surgery. Some surgeons perform thyroid surgery and as outpatient basis. Patients who undergo to total thyroidectomy have their calcium level monitored for heterogenic hypoparathyroidism. So after the thyroid surgery, the calcium should be evaluated at least for 24 hours to identify any heterogenic hypoparathyroidism or hypoparathyroidism secondary to thyroid ischemia, parathyroid ischemia, which is transient. Long-term monitoring, the patient should be evaluated after the total thyroidectomy and should be replaced with the levothyroxine, and a thyroid function test should be done 6 to 8 weeks after the thyroid surgery. Patient with thyroid cancer should be monitored for the disease recurrence, and thyroid cancer, especially with high-risk thyroid cancer, they need ablation after 6 weeks of the surgery. They need ablation of radioactive iodine. Complication of the thyroid surgery is hypocalcemia secondary to hypoparathyroidism. Rather, it's transient because ischemia of the parathyroid, or permanent hyperparathyroidism due to removal of the parathyroid gland during the surgery. And report transient hypocalcemia vary in the literature from 5 to 50%. It's rare permanent hypocalcemia secondary to hypoparathyroidism, lasting more 6 to month, and is between 0.5 to 2%. The parathyroidectomy behind transient hypoparathyroidism and hypocalcemia is not well understood, but thought to be related to transient ischemia, as I said before, to the parathyroid gland due to manipulation of the thyroid manipulation during the thyroid removal. Symptomatic review of the systemic review of predictor of post-thyroidectomy hypoparathyroidism found preoperative parathyroid hormone, preoperative vitamin D, post-operative change in the calcium to a biochemical predictor. Patient who had increased risk for the complication that with Graves' disease and with malignancy, because it's diffuse disease and malignancy is advanced, and maybe undergo total thyroidectomy and total thyroidectomy with central compartment neck dissection. So any difficult surgery, it's liable to complicated with the hypoparathyroidism removal or ischemia of the hypoparathyroidism. So the calcium should be monitored after the total thyroidectomy. Injury to the recurrent laryngeal nerve, it's common for non-expert surgeon. They can do the palsy of the recurrent laryngeal nerve, which do the partial or complete paralysis of the vocal cord, resulting to the hoarseness of voice, or a blockage of the trachea, and the patient need tracheostomy to breathe. So it's 1 to 2% of thyroidectomy is complicated and recurrent laryngeal nerve palsy. So a patient suspected recurrent laryngeal nerve injury should be evaluated for flexible laryngoscope or video laryngoscope to confirm the position and movement of the vocal cord. The impairment corrective procedure for vocal cord paralysis are not entertained until 9 to 12 months have passed. At this point, any persistent injury may be considered impairment. Should they have aspiration or dysphagia symptom, they should be evaluated to speech language pathologist, and patient with suspected bilateral focal cord paralysis may be required urgent definitive airway management as tracheostomy. So the total the paralysis of both vocal cord ended by blockage of the airway, and they should underwent to the urgent tracheostomy to breathe. Infection is a common, another common complication due to inflammation and bacterial infection of the thyroid bed and thyroid scar. The usual presentation is fever and chills and the leukocytosis. A patient needs a systemic antibiotic treatment. Thyroid storm, it's a common complication if the patient not performed and not prepared in a thyrotoxic patient. They should undergo to preparation of the antithyroid medication till the euthyroid then pushed for the surgery. It's a serious complication and fatal complication may lead to patient death. I will show you the video about thyroidectomy.
If you have a problem with your thyroid gland, your doctor may recommend a thyroidectomy. Your thyroid gland is located over your larynx or voice box. It wraps around your trachea or windpipe. Your thyroid produces a hormone called thyroid hormone and secretes it directly into your bloodstream. Your body uses thyroid hormone to increase your energy and raise your body temperature when necessary. For example, these effects help offset the heat your body loses when exposed to cold weather. Your doctor may recommend a thyroidectomy if you have certain thyroid cancers, an enlargement of the gland called a goiter, benign nodules, cysts, or an overactive thyroid. Before your procedure, an intravenous line will be started. You may be given antibiotics through the IV to decrease your chance of infection. You will be given general anesthesia. A breathing tube will be inserted through your mouth and down your throat to help you breathe during the operation. To begin, your surgeon will make a small horizontal incision in your neck. Depending on the reason for your surgery, your surgeon will remove one lobe of your thyroid or the entire gland. Your surgeon may put a surgical drain in your incision to remove excess fluid. The drain will remain there for a day or two. At the end of your procedure, the incision will be closed with stitches, staples, surgical glue, or closure tape dressings. After your procedure, your breathing tube will be removed, and you will be taken to the recovery area for monitoring. Your surgeon may check your larynx for injury. You'll be given pain medication as needed. You may continue to receive antibiotics through your IV. Most patients are released from the hospital 1 or 2 days after the procedure. Your doctor may prescribe calcium supplements. If your entire thyroid is removed, you will take daily thyroid hormone replacement medication.
Okay. We go for the second lecture today. I will talk today now about the difficult case of the severe hypothyroidism, not responding to medical treatment, how we approach these patients, because it's difficult and usually coming to our clinic, patient not responding to the high dose of the thyroxine. As one of you asked me about what's the maximum dose of thyroxine, usually if the patient use 1.9 per microgram per kg or more than 2 microgram per kg, patient labeled as refractory hypothyroid, and you should work and to know the cause of the refractory hypothyroid and not responding to the medical treatment. What shall we do? I will present one case we faced here in our clinic, and it's a difficult patient using large doses of the thyroxine. We saw one patient in my clinic, is 19 years old female patient, as non-primary hypothyroidism and on thyroxine replacement, and she known to have type 1 diabetes and insulin pump with good glycemic control, and she's stable thyroid function, was seen in endocrinology clinic since July 2016 with symptomatic hypothyroidism, fatigue, ability, and cold internals, dry skin associated with rising TSH level, requiring increment of the dose of the thyroxine. She was complaining at that time with chronic nausea and vomiting and fullness. Gastroparesis was confirmed by upper gastrointestinal endoscopy. Adherence to the levothyroxine therapy was confirmed by history of and also pill count, because the compliance of the thyroxine therapy is uncompliance with the thyroxine therapy is associated with high TSH and uncontrolled hypothyroidism. This is her investigation shows that TSH is very high, around 819, while the upper limit of the normal range up to 4. So she was severely hypothyroid, while she is using around 200 microgram per day, which means at around 3 microgram per kg for her. She was using high dose of the thyroxine, but she had uncontrolled hypothyroidism, and she is taking a very trusted patient. She is taking her medication regularly, and because she had gastroparesis and malabsorption of the thyroxine, that's the cause of the high TSH. So we confirm the other we confirmed the diagnosis again. We repeated, so it shows TSH was 514, still very high. And at that time we don't have free T4. Cortisone was around normal. Prolactin was normal. Prolactin high because hypothyroidism can cause hyperprolactinemia. Vitamin D was also low. She was controlled high diabetes around 8, the hemoglobin A1C, and adrenal insufficiency was ruled out by doing short synectin test and ACTH and AM cortisol. And also the other causes of the malabsorption in type 1 diabetes, celiac disease. Celiac disease was ruled out by the screening negative celiac disease. Cortisone was after 1 hour of the 60 minutes of the short synectin test is 900, so is normal response to the synectin. So the dose the adrenal insufficiency was excluded. ACTH was normal in this patient, so is also primary adrenal insufficiency was excluded. So the cause of this patient is this is anti-GAD antibodies was negative, so no celiac disease in this patient. She was not tolerating high dose of L-thyroxine loading dose because the diabetic gastroparesis and medical treatment of gastroparesis was tried by using metoclopramide, which decreased the nausea and vomiting. And Zimbridone also was tried but failed. Jejunostomy tube was advised by gastroenterology and was unfortunately the patient not tolerated and refused it. So we use to treat her by another modality of treatment by using levothyroxine, parenteral levothyroxine, 200 microgram, 3 times weekly intramuscularly, and was controlled for continue for 4 weeks. Then she was shifted to the usual dose of oral levothyroxine. Her hypothyroidism and gastroparesis symptom was improved dramatically. Her TSH and free T4, she had stable thyroid function for 15 months after the intravenous levothyroxine for 4 weeks only. Then the oral replacement of levothyroxine was resumed again. Her thyroid function test after correction of the IV thyroxine was repeated and TSH was 0.28. You remember that TSH was 800. So she's dramatically improved after intravenous thyroxine for 1 month loading dose. This is her figure from November 16 to January 18. This since that for 1 year she has rising TSH level. So the patient has rising TSH. So the IV L-thyroxine was given for 4 weeks in October 2017, and from January, after the October till the 2019, her thyroid function test was very stable, and also the correction of the hypothyroid also improved the gastroparesis. So this is a successful success story for difficult hypothyroid patients secondary to the malabsorption or intolerance of the thyroxine or thyroxine, because the common complication of diabetes is gastroparesis. So we reported this case about in literature, me and Dr. Vander. this rare case with the levothyroxine malabsorption and induced by gastroparesis and type 1 diabetes, and we report this in the literature because it's very rare case and very respond to the IV loading of IV levothyroxine. So also we talk about refractory hypothyroidism as clinical laboratory finding referred if the patient using a large dose of the thyroxine 1.9 microgram per kg. We should think about refractory hypothyroidism, and you should investigate what the cause of this patient not responding to the usual dose of thyroxine, and you should identify the cause. The cause of malabsorption of the thyroxine refractory hypothyroidism, the most common is the patient compliance. Patient adherence to the treatment is most important. Some patients feed up with the treatment and they claim that they are taking their medication regularly, but actually they are not taking their medication. This is the common finding in young patient. They are not adherent to their medication. So how we identify these patients? We should ask about the adherence, and we should count the pill counting, and sometime we should do the observed treatment in the clinic. Usually in the clinic we give full dose of the 1 week dose. We'll give the patient at the clinic, then we'll observe the effect of the uh, dose after 4 weeks to see the rising the decrease the TSH, or we'll do the absorption test, loading dose of the L-thyroxine. Then we'll measure the free T4 after 2 hours. If the thyroxine free T4 increase more than 1.4 units per deciliter, this indicate the patient is not adherent to the L-thyroxine. Some medication cause a low decrease absorption of the thyroxine, like iron or calcium. They should avoid taking this medication in the same time of the thyroxine. Thyroxine should be taken in the empty stomach, and the patient should wait for 2 hours to take any food after. And also the other causes is malabsorption secondary to the Helicobacter pylori, celiac disease. If the patient has weight gain, they need more than the usual dose, or a patient become pregnant, they need more thyroxine. Addison disease is the one cause of the hypothyroidism and refractory hypothyroidism. And also the storage of tablets. Some patients they store the tablet in the refrigerator and freezing or exposure to the hot or cold weather. It's destroy the thyroxine. So non-pathological causes is non-compliance. So this is the most common cause of refractory hypothyroidism, and also the thyroxine absorbed primarily in the ileum. Timing of the injection is important, so they should inject in the empty stomach. They should wait for 1 to 2 hours. Some medication should be avoided in the same time, like taking with the thyroxine, like vitamin D medication, proton pump inhibitor, histamine receptor, cholestyramine, and calcium iron. Pregnancy, this is the most common cause of high TSH and rising TSH. So pregnancy needs more thyroxine replacement. Pathological causes, any GIT disease like Helicobacter pylori infection, inflammatory bowel disease, celiac disease, atrophic gastritis, gastric bypass, biliary pancreatic diversion, gastroparesis. like our case. Change in body weight, increased weight needs more thyroxine. So if a patient increased weight but he didn't change his or her dose, they should increase their dose. A diagnosis and managing refractory hypothyroidism. Key points: confirm diagnosis, low free T4 and high, very high TSH. Ask about compliance. Poor compliance, the most common cause of the thyroxine rising TSH in patients with hypothyroid. Patient will knowledge occasionally they are forgetting their doses. We should asking about compliance and adherence to treatment. Adherence therapy be directed by patient report and clinical impression of the frequency and pharmacy refill, and also bill counting can be take consideration. Supervised test for the levothyroxine absorption is advised for patient to identify these patients with non-compliance. Check patient medication bottle and tablet. Pharmacy error can also occur because they take another medication, expect this is thyroxine or not, resulting in tablets inside the bottle that are not same dose reported in the label. Check appropriate storage because protection from the light, moisture, temperature, extreme destroy the thyroxine. Review the thyroxine ingestion tablet and empty stomach should be avoid to take any medication 30 to 60 minutes after ingestion of the thyroxine. Investigate for levothyroxine malabsorption and in affinity of GIT absorption. Perform thyroxine absorption test, as I said before, and measure loading the dose of 1000 microgram and measure the serum thyroxine after 0 to 2 hours. And this is the type of the ingestion. After 2 hours, the diagnose usually the in the malabsorption, the thyroxine not rise to less than 1.7 microgram per deciliter, 22 biomole per liter. If the thyroxine rise after 2 hours more than 22, so this indicates a patient compliance issue. A patient not taking her medication regularly. That's the when they ingest a high dose, the reflex of the free T4 is very high. This is indicate if the rising more than 22, this is adherence issue. If less than 22, it's indicate a patient had malabsorption. Then the patient should be evaluated accordingly. Case report, the levothyroxine malabsorption also reported like our case. They use intramuscular injection for these patients, like our patient. We are using interference, and this patient, their patient, they use intramuscular injection weekly doses. And also their conclusion about the patient with type 1 diabetes with gastroparesis was associated with impaired thyroxine malabsorption. Their experience suggests the rational management of this problem was using intramuscular levothyroxine injection or oral soft coated capsule. This is the other modality to give the patient thyroxine either by intramuscular or gelatin coated thyroxine. Is very effective for replacing a patient with thyroxine with thyroxine malabsorption. So another case report about gas patient with thyroxine malabsorption was treated with capsule, gelatin coated capsule. It's very effective like intramuscular injection and can replace the oral treatment of thyroxine. So in patient with uncontrolled hypothyroidism, despite adequate treatment and titration, gastroparesis should be considered as a possible mechanism of malabsorption, particularly in patients with the risk factor such as diabetes mellitus, and gelatin-coated capsule formulation of thyroxine sodium may be effective alternative treatment for patient with gastroparesis. This is gelatin-coated thyroxine is prevent to be destroyed in the gastrointestinal tract and easily absorbed in the ileum. So it's actually, unfortunately, it's not available in Saudi Arabia. It's available in the United States. It's very effective in patients with malabsorption because it's coated with gelatin. It's prohibited to be destroyed by gastric acid and easily absorbed in the ileum. This is the form of the gelatin coated thyroxine. It's all forms of the all strength of the thyroxine. So the tyrosine cost about 134 dollar per packet. So conclusion, diabetic gastroparesis should be considered for patient as a cause of L-thyroxine malabsorption. And diabetic patient, we don't who don't respond to the tolerant to the oral thyroxine therapy. Intravenous thyroxine can be considered as an alternative way to treat these patients if gelatin levothyroxine form is not available, like our situation, our patients, and if the patient didn't tolerate intramuscular levothyroxine injection. I want to thank you, and I will stop now for a break for Isha prayer, and inshallah we'll come together to the last lecture and with for thyroid interpretation and cases, practical case for thyroid function test. Inshallah, we'll meet together 8:30 p.m. بإذن الله عز وجل. طيب بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. I thank you for attending this course. This is the last question and the last lecture today, inshallah. It will conclude our 3 days course of the thyroid disorder. Inshallah, it will be very helpful. And this is the last case interpretation. The most common thyroid function test we are facing in our clinical practice and in the laboratory, and also in the thyroid function test, which seen by a doctor or any physician. We'll talk about, if you want to answer, you can answer in the chat box, which choice, the best choice. You can interact with the chat box, write the right answer. The question, which of the following laboratory value are consistent with the diagnosis of Graves' disease? Number 1, thyroglobulin concentration undetectable, TSH suppressed 0.1, free T4 0.9, or number 4, total T3 350. And this is the normal range. Which one is consistent of the Graves' disease? You can A, B, C, D. Choose the right choice if you want to participate in the answer. Think about this one. I will give you few seconds, 30 seconds to answer this question. Which choice is better? Interpret the thyroid function test in Graves' disease, hyperthyroidism. I will give you 30 seconds. Yes. C. It's indicated this Graves' disease feature. T is it's suppressed and free T4 high. This is the pattern of the hyperthyroidism: free T4 high, free T3 high, TSH suppressed. This is called hyperthyroidism. Some of hyperthyroidism thyroid function test is presented with either free T4 high or serum free T3 high with TSH suppressed. So TS suppressed is hyperthyroidism indicated, and free T4 high or plus minus free T3. 27 years old woman, symptom of diarrhea with palpitation, increased heart rate, weight loss despite increase in appetite, and she had heat intolerance. TS is suppressed, and free T4 is very high, double the normal level. Hyperthyroidism, Graves' disease, was diagnosed. Which of the following would be initial treatment? 1, propranolol 20 milligram 4 times daily, iodine contrast 10 drops TID, carbimazole 5 milligram TID, radioactive iodine therapy 100 millicurie. Which one you think this is? Which statement is right? A, B, C, or D? I will give you seconds to answer this question in the chat box. Okay. D, number 5. Number 5, radioactive iodine. I think one of you chose B, which is 1 اللي هي propranolol. Yes. 1, 3. Yes. I think 50% of you chose the right answer. Right answer is B, beta blocker and carbimazole. This is the best treatment of the initial treatment of the Graves' disease, control heart rate and control the hyperthyroidism. After the control, we can give the patient, if no contraindication, no pregnancy or lactation, will give the patient radioactive iodine. Radioactive iodine, the best treatment, but not high dose like 100 millicurie. Will give 10 to 15 millicurie. But CCK is reserved for severe hyperthyroidism and or preparation for surgery. Who chose B? This is the right answer. Okay. طيب. Which of the following laboratory test change will be expected in factitious thyrotoxicosis? Factitious due to thyroxine injection. Free T4 should increase. Free T3 should be increased. TSH decrease. Thyroglobulin should be increased. Thyroglobulin should be suppressed. Which one is a feature of factitious? Factitious is ingestion of thyroxine. Only injection is not disease, only the patient take thyroxine dose. Which one you think this is due to L-thyroxine injection without any disease? Free T4 increase, free T3 increase, TSH decrease, thyroglobulin should increase, thyroglobulin should be suppressed. I will see your answer. Okay. 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 صراحة you are very smart. Who chose the answer B? This is the right answer. 50 to 60% of you chose the right answer. Free T4, it's increased by thyroxine. Yes. Free T3 increased, TSS suppressed, and thyroglobulin suppressed. Thyroglobulin suppressed by thyroid levothyroxine. If it's due to disease of the thyroid, like Graves' disease, thyroglobulin increased. So thyroglobulin is differentiate between the thyroid disease causing the hyperthyroidism or and also the thyroxine ingestion. How you differentiate? You'll measure the thyroxine. If suppressed, it's due to thyroxine ingestion. And we have patients, especially young patients, using thyroxine for weight reduction. Very interesting. Okay. Which of the following would be most appropriate initial therapy for old women with cardiomyopathy and TSH? TSH is 50, so free T4 low and TSH high. She is primary hypothyroidism. Which dose of thyroxine should be started in this patient with cardiomyopathy with hypothyroidism? Which dose? Shall we start 65 microgram daily, milligram daily, or 75 microgram daily, or 25 or 65 milligram Q daily? Which dose of thyroxine should be started in advanced age with cardiomyopathy? C, okay. I think 100% of you chose the right answer. Right choice is 25. And these patients will start with low dose and build up the dose every 2 weeks to avoid any advanced cardiomyopathy. You are right, mashallah. Thyroxine, as I said before. Following initial thyroid replacement therapy, the most appropriate follow-up interval. When you change the medication, when you will see the results, should be repeat the thyroid function test. Is it 1 week, 2 weeks, 3 weeks, 4 weeks, or 6 weeks? Which interval to assess thyroid function test if you change the dose? Okay. Let's see. طبعا I think okay, okay, I think 60% chose D of you chose D, but the right choice is E. E 6 weeks to assess TSH, 4 weeks to assess free T4. Who chose E? 6 weeks is the right answer. Okay. 6 weeks initial monitoring, dose adjustment, steady state of TSS concentration are not achieved for at least 6 weeks. This is in up-to-date 2022. So TSS should be assessed after 6 weeks of the adjustment. طيب. 38 years old woman is admitted with possible myocardial infarction. Her blood pressure is very high. Her pulse is high, 130 beats per minute, irregularly. So she had AF, and she had temperature 100 Fahrenheit. Uh, she is finding include lead lag sign of the hyperthyroidism or thyrotoxicosis. She had diffuse thyroid gland without any nodule with moist skin, so she's in hyperthyroid state. New onset atrial fibrillation. Laboratory test was suppressed TSH and free T4 very high. The upper limit is 1.4. So she is in thyrotoxicosis and symptomatic thyrotoxicosis, and radioactive iodine uptake shows was increased. What is the most likely cause of the patient thyroid disorder? This is the thyroid uptake scan, shows diffuse uptake of the thyroid. What this thyroid uptake scan, which disease diagnose? Is it toxic adenoma, this picture, Graves' disease, toxic multinodular goiter, or subacute thyroiditis? What do you think this thyroid uptake scan for this young lady with hyperthyroidism? Okay, ما شاء الله. يعني okay. I think 70 of you choose the right answer. The right choice is B, Graves' disease. Graves' disease is diffuse uptake. If it is toxic adenoma, only localized uptake. If it's toxic multinodular goiter, there is nodular uptake. If it's thyroiditis, no uptake. So this picture is Graves' disease diffuse uptake. Graves' disease. 70 years old woman, 23 years old, has gained weight, feel mentally sluggish and tired easily, and physical examination has puffy face, developed deep tender reflex, delayed deep tender reflex, and she had enlarged tongue, enlarged thyroid. Laboratory test was free T4 low and TSH is very high. This or the lady is primary hypothyroid, and radioactive iodine scan was decreased. طيب, which best management of this patient? Levothyroxine 0.12, it's around milligram, يعني 11.2 milligram microgram, or this is 100 milligram TID, or beta blocker, or radioactive iodine, or levothyroxine 50.5 يعني 50 microgram. Which dose should be started in this old lady, advanced age? What do you think? Is it 50 microgram, or 11.2 microgram, or 100 milligram? 3 times daily, or 20 propranolol or radioactive iodine? What do you think? طبعا I think this is difficult case, but I think the who chose A, this is the right answer, A. Low dose thyroxine is advisable for this old lady, and to be adjusted after 2 weeks. 25 or less than 25 يعني advised to starting dose. 25 microgram or less than 25. So no 25, only 50-50 is not advised, because advanced stage or cardiomyopathy should be start 25 or less. So levothyroxine is advised for this lady with low dose 0.11 milligram. It's equal to 11.2 microgram daily, once daily. Thyroxine is given once daily. This patient underlying Graves' disease underwent a definitive treatment of the long-term. She had received radioactive iodine, and she became hypothyroid and hypothyroid levothyroxine replacement. She developed thyrotoxicosis and TSH 0.005, so TSH suppressed and free T4 is very high. When we do the uptake, there is low uptake. Low uptake, it means thyroiditis. Thyroiditis or not disease or overdose. Thyroglobulin level, what we call low thyroglobulin. Low thyroglobulin, it means factitious. Factitious, because low thyroglobulin. What's the most likely diagnosis? Graves' disease, thyroid nodule, thyroid carcinoma, subacute, none of the above. What do you think? A? No. None of the above. This is factitious hyperthyroidism, because high free T4, low TSH, and thyroglobulin suppressed. If thyroglobulin high, it means due to thyroid disease, but thyroglobulin is not is decreased because she is take more dose of thyroxine, overdoses of thyroxine. This is factitious thyrotoxicosis due to excessive dosing of the thyroxine. 50 years old housewife complained of progressive weight gain, and for 1 year fatigue and memory loss, deep voice, symptom of hypothyroidism. TSH concentration is very low. Free T4 also عفوا TSH free T4 is low, TSH is low. So she has low TSH and low free T4. She is 50, and serum cholesterol is high. This is symptom of hypothyroidism. What is the most likely? Is it central hypothyroid, primary hypothyroid, subclinical hyperthyroidism, primary hypothyroid? Which one is the diagnosis? Can you answer, please? She had low free T4 and low TSH. MashaAllah, tabarakallah. 100 of you percent chose the right answer. This is a feature of central hypothyroid due to pituitary, because she had low free T4. This is hypothyroid. If TSH normal or low, this is indicated that the patient is central hypothyroid. What's the replacement? Thyroxine, which we monitor, only we monitor free T4, not TSH. When we adjust the dose, we'll adjust according to free T4 after 4 weeks. Central hypothyroid. This is the normal thyroid, normal TSH, normal free T4. hyperthyroid, low TSH and high free T4, hypothyroid primary, TSH is high and free T4 low, hypothyroid centrally or secondary, low free T4 and low TSH. I think this is the last question. It's 55 kg, 50 years old housewife presented with a free T4 concentration low, very low, free T4. Free T4 هنشوفها كم. Free T4 up to a normal free T4 and TSH was suppressed. TSH is suppressed and free T4 normal. What we call this one? Clinical hyperthyroidism. Subclinical hyperthyroidism. عفوا. She is what? She is central hypothyroid. عفوا. She is central hypothyroid. That she has asymptomatic except for mild fatigability and was taking thyroxine 50. Thyroxine 50 in central hypothyroid, usually we adjust the dose according to free T4. Free T4 0.5. What's the normal range of the free T4? Free T4, this one, 0.7 to 1.8. So she's had suppressed free T4 and she is in 50. What we'll do? Increase the dose to 75 microgram, decrease the dose of thyroxine 25, keep the dose 50, none of the above. What do you suggest? This is central. As we said before, we adjust the dose of free T4. We are not depending on TSH. What do you do? Can you answer, please? Okay. C. No, not C. D. لا ما هي دي. This patient with central hypothyroid, free T4 low, TSH low. She's on 50. As I said before, we adjust the dose of free T4 of thyroxine according to free T4. Free T4 is low, so we should increase the dose to 75 because a patient under replacement, we increase the dose of L-thyroxine according to free T4 because she is central hypothyroid. We are not concerned about TSH because she is secondary hypothyroid due to pituitary. Pituitary is secreting TSH, so in this disease is not depending on TSH. We are depending on free T4. So increase the dose to 75 microgram daily because it's patient's central hypothyroid. And we'll follow the free T4 to be in the normal range. I want to thank you all for interactive with us and for the thyroid function test and interpretation. I want to thank you for attending this course. I think it's inshallah it will be very helpful for you in your clinical practice. I want to thank also the Durat Riyadh for arranging and participating in the technical support for us. I think you are welcome and you are very interactive with us and helping us to continue more lecture about thyroid and diabetes and endocrine diseases. If you have question, I am ready to answer before we totally conclude this course. If you have any question about the lectures which delivered to you for the 3 days, I am ready to answer. If you don't have any question, I will conclude now. طيب أشكركم جميعا على حضوركم هذه الدورة وأسأل الله عز وجل لكم التوفيق والسداد وصلى الله وسلم على نبيه محمد وعلى آله وصحبه أجمعين.